Okay, people are joining the webinar. So time for us to wish you a warm welcome. Welcome to this new webinar in the series. And we're very excited with a very international group of people who registered, 36 countries. Always great to see, and it kind of underlines that there's really, an international need for education sharing, information sharing, experiences, and well, we're thrilled to contribute to that effort today here with you. So we'll give it a few more minutes for people to get in. And as soon as we're there, we'll get started. Okay. So welcome to this Eaglet Eye webinar, Total Profilometry, Utilize, Integrate, and Grow. So it's of course it's so important to understand the clinical use and how for profilometry, how you use profilometry effectively to fit specialty contact lenses. But we get a lot of questions also on how to integrate a system like this into your patient workflow, and how to grow your specialty contact lens practice. We're so thrilled here this evening with a very special guest, a long time ESP user, a great friend of the ESP family, and Dr. Barry Leonard. So let's get started. I will first introduce the technology, so it falls into place. There's a framework set, so I will do that, and from there, Dr. Leonard will take over. So iSurface Profiler, what makes us tick? It is the ability of this technology to measure the full front surface of the eye. And for me, what illustrates that so well is that central image you see there. And you see the line pattern on this black and white photo. You can also notice that the eyelids have been held open here. And you see a complete coverage from one end to the other, covering the full cornea without any holes in the data. And you see that those line patterns, they're equally dense right in the periphery as they are in the center, at the apex of the cornea. So all of that information is taken and is then calculated into a 3D height model of the eye, about 500,000 data points. And this is a very quick measurement process, takes just a few milliseconds. Of course, you need to go through the whole measurement procedure. So all in all, you say 3 to 5 minutes per eye, and you're done. That's the essence of what we do. And with this technology, you should actually see this as a platform that will allow you to take care of the whole fitting process. So of course, you start with making a scan. You want that 3D data. Then in the software, you can then start to analyze that information. And actually later on in the webinar, Dr. Leonard will actually go to the actual software to further illustrate. Because if you look at the real software, it talks a much clearer story than the PowerPoint slide can do. And in step 3, there are the lens fitting algorithms. And so these are very precise, sophisticated algorithms that match that measured front surface of the eye with the back surface design of the lens. And then step 4 is an ordering system, and that ordering system will push out the fitted lens that was done in step 3, but it will also push out the ESP measurement file to the lab of choice that you choose. You're always in control what lens design and what lab you want to work with. And They, on the other hand, have a copy of our software. They have been trained by us, so you will always be able to have an informed discussion with them over should that be necessary with the professional affairs team at the other end. So we have an open platform. You see, there's a ton of different lens designs from different lens manufacturers. We want you to continue working with your lens, your preferred lens, and your preferred lab, and that one professional affairs person that you have such a good connection with. You know, we want you to continue doing that. And also, this system allows you to measure all modalities of specialty contact lenses, not just sclerals, but also ortho-K, RGP, soft, and hybrid, of course. So this device potentially could be the powerhouse for growth of your specialty contact lens practice. Enough about the product. I hope the general outline is clear, and it's my absolute pleasure to now introduce Dr. Barry Leonard officially here for this webinar. And he earned his bachelor degree in science in biology from the San Diego State University, and then on with a doctorate of optometry from the Southern California College of Optometry. And he is adjunct clinical professor for the Western University of Health Sciences, also of the Pacific College of Optometry, and the Pennsylvania College of Optometry, Salus University. Dr. Leonard is a member of both the American Optometric Association as well as the Californian Optometric Association. He currently practices at the Dr. Barry Leonard and Associates practice and is director of the Californian Keratoconus Center. And I always love adding that Dr. Barry Leonard is an avid triathlon athlete, still going strong there. I mean, deep respect. And from a clinical perspective, he's a keratoconus patient himself, and that gives him a lot of kind of weight and connection with his patients. So without further ado, let's switch to Dr. Leonard. We'll just kind of switch screen or presentations as well. So give us a second to do that switch,
Right.
And then Barry will take over.
Okay, thank you. So I think you see my screen, the first case report now.
Yeah.
And we're ready to go. Thank you for the introduction, Arnie, and good evening from Southern California. Wherever, I know there's people from all over the world tonight, so whether you're having breakfast or getting ready for bed, thanks for joining us. So I wanted to go over a couple of cases, and because part of that is how I market, to show a little bit how I market these things in the office. And then we'll talk about sort of some of the things that we do outside the office. So this first case, I mean, we all look at sclerals and we all look at things, but we still fit, corneal RGPs, or at least I do. And I think that's still a part of what we do. And what I have found, the eaglet is very powerful in that also, because you get good corneal information and corneal elevation information. So this case, they had a 69-year-old female. She'd had RK from a way long time ago. They tried to fix things up with PRK. She had IOLs in her eyes, and she just was not doing real well in her current RGPs. Every patient in our office, as part of our screening, before we get into anything else, is going to have our NIDEC OPD, as well as other health checks, Optos and Fields and that. And right away, we could see sort of classic, old RK kind of an eye. And I looked at this and I said, wow, well, that left eye down there on the bottom looks like that should be pretty straightforward. The right eye sort of looks a little offset and a little funny looking topography. That's probably going to be where all my work is. But as most of the things we do in optometry, things didn't really turn out the way I thought. And this is a good axial shot of that, similar to what we get over here with the OPD of that left eye, which turned out to be a very difficult fit. That right eye went well, right on first lens, good comfort and good vision. So I went and looked at some more data from the eaglet, um, and then we ordered our first pair of lenses. And again, that right lens, 20/20 and comfortable. The left lens I was using a Rose K2 IC lenses here, which some of you might be familiar with, a reverse geometry RGP, which some of you might have that or different things in your countries. And there was just a lot of lens awareness, a tight feeling. VAs weren't that great. So probably another one of your best topographers is fluorescein, as we know. There's that sort of matching up what we saw that we would look at if we looked at this elevation map. So you can really see that. And this is what I went to. On this one I called in one of my consultants at our lab and said, what are we going to do here? How are we going to get this a good fitting lens and a good comfortable lens? So we're going to work on that, look at those elevation maps. I called consultation, and here's the next lens we got. And it looks a lot better. It looks like things are a little more evenly based. It's got a toric marker there at the bottom. This is based on the elevation map, what we got. And again, she's now very comfortable, but the vision got even worse from 2050 to 2060. I put this over refraction up in front of the patient in the chair. She's 20/20. Boy, this should be easy. Let's put that in there and go. And now we got to 2250. Things got worse. And because now what I found out, when they did her IOL surgery, the surgeon put a toric IOL. And that's a discussion I have with all my surgeons. And that's again another way that I have relationships with other referral sources is discussing these cases. And now more and more as my keratoconic patients are aging up, they're going to need cataract surgery, and what kind of lens is going to get in there. And generally, a toric IOL is just going to cause more problems than not. So we sort of redesigned things. We're back to some spherical optics and a toric PC, and now we got back to the 20/20 VAs and very comfortable. And she never thought she'd see that way. But this is a large part due to the corneal elevation maps that are very valuable in the eaglet. And again, I think a lot of us overlook how powerful the corneal information is as well as the scleral. But and there was the final lens, and she was just very happy.
So Dr. Leonard, what made this eye from a fitting perspective in your view? What made it such a challenging eye to fit a lens on?
Well, she'd again had multiple surgeries. She'd had the RK surgery from way back. And then they had tried to clean it up with a couple different PRK attempts. So you've got a very, very irregular shape and a very unusual shape. As we all know, the RK are tough enough as it is, and then you add on the PRK. And again, looking at the original topography, I thought we're going to be okay, but there was just a lot more going on. And then internally, you have a toric IOL, internal lens implant, and just really got our optics. So this bitoric lens just caused all kinds of cross cylinders in that. So hopefully that
Awesome.
answers the questions. If anybody has any questions, I think Elena is monitoring the chat and she can let us know if anything comes up. And then I want to do a quick second case. This is a gentleman that I had seen way before I had eaglet. And his wife was a patient of mine. She was a LAPD officer, a sergeant, and he was an educator, wanted to be in law enforcement. So he had LASIK, and I guess he got ectasia. He called it LASIK 3 times, had a bunch of enhancements. And here was his glasses prescription, high astigmatism, 20/40 in the right eye and 20/20 minus in the left. So he wasn't real happy. He needed to have better vision than that to get into the law enforcement. So I had fit him in Kerasoft lenses. We're limited, a lot of law enforcement is having soft lenses and not a rigid lens of any kind. Even a Synergize or hybrid's not going to fly. So we fit him with that, and the right eye was a very struggle. And again, I don't have eaglet at the time. We had to go to a quadrant specific Kerasoft soft lens, and we still could only get about 20/40, but we could get something to sit on his eye. The left eye was a lot easier to get to 20/20, but it was very difficult. But that's all we could do for him. Here was some pictures of those interesting looking corneas that have had all those surgeries on there. We've got all different elevations and a lot of distortion on that right eye in particular. So he disappeared. That was almost 10 years ago. He disappeared for a while. Then he came back now more recently, last couple of years ago, with now that I have eaglet. And he said, I want to see better. What else can we do? And I explained to him, scleral lenses. He was very skeptical. He's a guy who reminds me of Arnold Schwarzenegger. He's about the same size. He's German Austrian, has that same voice, but his mind is like an engineer. And he's always, Daddy, you must make it better. And he would give me good feedback, but he's a fun guy, but a tough patient. And so I said, you got to trust me, and let's go this way. And here we're going to go live to we're going to bring up our eaglet software. Just take a moment here. We'll switch screens. There we go. You guys see that now?
Yeah,
Okay.
perfect.
So here's what we saw. Here's the eaglet, and we said, wow, there's a lot of toricity. And this is probably why I had so much trouble fitting that soft lens. And if we start running some chords, is what we all know to do, even at a 13 millimeter chord, there's 460 microns of toricity, which I thought, wow, that's a lot. And then I say, well, let's go out and we're going to make them, I think, a 17 millimeter lens. Let's go, whoops, where did I go to that? There we go. And there's almost 1,200 microns of toricity out there at the edge. So this was, to me at the time, was my record. I think I have another one that's more since then, but it certainly explained to me why my Kerasoft lens wasn't doing well, and why we can do better, though, if we are going to fit a soft keratoconic lens like Kerasoft or Novacones. You can certainly get a lot of information off this. We don't have good algorithms yet for that, even though we're working on that, but it can tell you the shape of the sclera, which is very, very valuable. So let's see, what else do I want to show you here? That's probably good, Jen. Maybe we'll go back to our other screen. But that was just pretty amazed that we could have this much toricity in any one person. Okay, so picking out the first diagnostic lens, we got to put something on his eye to try to get an over refraction with a known base curve. And the best thing I could find just had edge lift, all over the place. That was one of the biggest edge lift I'd ever seen. So I thought that was pretty interesting. But I got a lens to hang on enough to get an over refraction. And here's the final lens that we ended up with. Very oblate lens, but you can see the amount of toricity in that lens that we put in there to get this good. We got him to 20/20 in that bad eye. And of course, he said, not only do I see better than I've ever seen, but wow, it's even more comfortable than that soft lens that I have, which is always a surprise to patients. They're always concerned about hard versus soft. And then this is again the second eye, and we did that similar thing, and there was that beautiful lens that we really found. And as you can see, it's a very against the rule sclera, which I believe we all know is usually a little more difficult to fit. We can't really hang that lens on for that superior inferior to keep that inferior decentration, but we're able to get this sitting just really nice. You can see the dot over there on the right side of the screen. That's the flat meridian in this lens, which or the steep meridian in this lens, which follows our scleral profilometry just perfectly. And there again, the second lens, then we went and did that, and the same thing, that against the rule toricity, but a beautifully centered, comfortable lens for this gentleman. I put these screens, and these are just the same we saw with the live, just it wasn't sure it would all work. So I put those in there. And here's the lens. There's a nice picture under the lamp, but with our serial numbers and those hash marks on this lens is the flat meridian. It's just lined up perfectly with what eaglet would predict. And there was that beautiful scan over. That's again the vertical scan. You can see how well centered that is, which I was very surprised at high plus lens, but we could really design a lens. And I think back to when I used to try to do these lenses before eaglet, would I ever gotten to 600 microns of toricity by doing my art, starting out with a couple hundred and adding a little more and a little more and a little more, how good would I have ever got? How much would I ever got without knowing what was out there?
Yeah, can you kind of from a gut feel, could you say so with such toricity, how much without profilometry, how many refits would that have been?
Oh, probably 10. I mean, I would have started off because even the kits back in those days didn't have that much to start with. They're spherical. So maybe I'd order, 100 this way and 100 that way, a couple hundred, and add another 100, maybe add another 100 or 50. How much would you even add each time? Because, we just move along real slow. So this process just took a couple lenses and we were there.
Right.
And that's adding, I don't put the front toric in right away. I don't do any of that, but that's adding the front toric. We could do that immediately. So that's a very good point, Arnie.
Thank you. We have a question in from Dr. Suzanne Donald. What is the max peripheral toricity your preferred lab can manufacture?
Well, what's nice now is in this, and that happened to be a Zen lens, and we have the bi-elevation. So you can, with the bi-elevation, I believe they said they could go to either 800 or 1,000 microns there, and then you could add more in the APS if you needed. But the bi-elevation takes the all the way out to the edge, and that's where we got most all of his, because as we saw, he had it from 13 millimeters going almost all the way out. He had over almost 500 microns right there.
So have you ever had a toricity that was too much that couldn't be handled, or not yet?
Not yet.
Not yet.
And I believe now with this newer design, in the past, if we were just changing that edge, and even if you put in 500 microns of toricity in just the edge, how much is that really going to do? But these new lens designs, Zen bi-elevation being one, but there's others doing that with these oval optic zones and basically making the same bi-elevation type of a lens. We can now use much more of the sclera to really hold that lens on there, because I don't think we'd ever get it with just the edge design. It just would decenter. We'd put it as much as we can. I hope that answered your question.
Yeah, thank you.
Okay. And the last good, great thing that we have with is looking for lumps and bumps on eyes with profilometry. And here's a typical cone. But then we looked, and there's that big old Pinguecula. There's actually two on this eye. And as we know, well, Gianni, I think we could switch back to the live for a moment. Let's switch to another patient, because I really want to show how we use this. And I've done this for Pingueculas as well as shunts and tubes that we have. Any other elevation, I've even done only a couple, but nodules on a cornea where we can actually measure those. Let's switch over. And both these patients, I know you see their names. I didn't know there's any other way to do it, but I've asked both of them if it was okay, and they both gave me their okay. So there's just a real typical cone that you all see a lot. And if you're not aware, you can see with hovering my mouse over here, we can actually measure the height of that lump. So we're at 366 microns, and versus next to it, you're almost there. So it's at least that or a little bit higher than that. And you can also measure the height, the width of that this Pinguecula. Now, what I want to show next is, let's see if that comes up here. Oh, we'll have to go back in a moment. But I have interns in my office. And an intern is not always going to have an eaglet wherever they work. And they've got to sort of learn, I'll date myself, but I originally learned things with a slide rule. And then I went to a calculator, then I was on paper and pencil, or I guess before a slide rule. Then I went to a calculator. And now I don't do any math in my head, of course. But I think these things you've got to do, the old way also to learn. So I make them do it that way to start. And so before I'm going to let them measure it here, we can look at a picture. And Johnny, if we go back to the presentation, if you look at a picture, and this is began before I had eaglet, and we were doing sort of older kind of lenses without, vaults and channels, or maybe just notches, we would sort of eyeball it and say how big something was. But we can certainly do a better job now. But what's interesting, we'll go back to our presentation, and we before the notch, before this microvault was there, we saw that big impingement at that area, and I said, okay, go ahead and design that microvault. There it is, and tell me how big you want it and what size. And let's see, I think we can go back, and there's an example of a microvault. But here was the first microvault they made right there. It was just a little too small. It wasn't covering that whole area. So then I said, go back to that map, like we just showed you live, and measure it and make it as big as it should. And those three little dots are surrounding the microvault. You can see that's how big it should have been compared to that little one. So that's just part of the learning process that we do. But when we do it right from eaglet, we can identify right off the bat how high, where it's located, at what axis, and what that width that we're going to have. This width from here to there is going to be all the way around. And we want it at the edge. We can also do tubes and shunts, and some of these we can do 2 or more of these microvaults or channels. Sometimes we can even go up to 4 if we need them for different purposes. So that's just another great use of our eaglet machine. But I know we want to talk a little bit tonight about practice marketing, and I look at that in 2 ways. One of it's in the chair with the patients, and the other, of course, is outside the office and bringing patients in. And the number one thing I've found is the eaglet has been the number one driver of patients into my office. I fortunately have a very good web designer. He's real into search engine optimization, or SEO. And one of the things we highlight is eaglet. And actually today I had 2 new patients, and both had done research, and both had mentioned, wow, you have this eaglet instrument. And what we started the PowerPoint off was that rotating view of the profilometry, and that's what really sells them in our chair. We'll go back to that live in a second. Maybe before we get into this. So, John, if we could go back, we'll go back live once more. It's a little awkward, but it's worthwhile, because when we have in the chair, I have developed something I call the Scleral method. Is what we all do is a stepwise walk through with a patient. And the first thing every patient in my office gets topography, because we have our autorefractor, topography, and wavefront all together. There we go. Thank you, Johnny. And I can show them that, and we can say, here are your keratoconus, and you have this and that. And then now it's time to do the eaglet measurements. And so we're going to get our scleral profilometry. And from that, the big thing is just this. I just sit there and show them this 3D model, and they start to understand what they are up against. And even the ones that come in here that have known they have keratoconus, have been fit elsewhere, and this or that, when they see the 3D model, and also we can then show them the elevation line drawing here, and you can even see that little bump from the Pinguecula there. But by showing all these things to patients in different ways, you can show them the steepness and the flatness of their cornea. And again, in this person, that big old bump there, we can say this is why we're going to design what lens. And when I started looking at the slope profilometry, this person has some toricity, but not as much. We can sort of see what they've got, but only 180 microns, which we know is sort of standard. But we can start deciding, well, what kind of lens do you need? Are we going to, do we need a, a toric lens of some kind? Do we need a free-form lens? Those kind of things. And this way we can just tell them why we are deciding, well, we need to go up and need a free-form lens versus a standard toric lens, or we're going to need to add a microvolt, and what other things that we're going to need. And they can understand why they need to then, spend the dollars and spend money. It just works amazingly well at that point. And uh, that's the main thing. Some people I'm going to show them more different scans if they, depending on what they like to see, and we need to show them. There's a lot of things here, and again, even the corneal elevation maps. There's your cone, and a lot of good data here to use. But again, the main thing is this, and then I can start right in the chair with them. I'll say, well, look, you have this much toricity, this much asymmetry, and just try to explain to them that Pringle shape to their eye. So it just works real well. So let's go back to our slideshow there, Gianni. And this also works well. I try whenever possible for my other referring doctors, optometrists, as well as my corneal, usually the corneal ophthalmologist, as well as I have a neuro ophthalmologist who's a good referral source for me. They're going to be seeing these strange patients also. I have a couple of rheumatologists also showing them this software and how it can work. And they're just amazed because they don't have any idea what we can do. They'll see the results later, but you want to show them how and why you're different from the others. And we've made this investment and that. So what I've done is a lot of different some infographics. I've got this one is a sort of a guide for other doctors. So my referring doctors, basically some, as we know, don't even recognize keratoconus to the degree they should. And we all get patients in our chair say, hey, no one said they could help me, and all I have is these glasses, or all I have is these disposable contacts that really aren't getting me to see very well. And so I'm just trying, educating those doctors at least to recognize the signs of keratoconus, because we screen every person on a topographer that comes in our office, but a lot of people don't screen them or don't even have one. So there's, as we know, there's scissor reflexes or prescriptions changing often, and there's other signs that they can look for. So I've developed this as part of my marketing to other doctors, and that's sort of that foot in the door of how we can work together on and co-manage these patients together. For the patients, I have another infographic. Do I have keratoconus, and different things that they're going to recognize: their blurry vision, their double vision, their glare and flare, and all those things. And of course, what are the risk factors? Other people in their family having it. Are you an eye rubber, which we now know is probably 100% connected with keratoconus, especially predisposed to that. And of course, what do I do if I think I have keratoconus? Well, call Dr. Leonard, or at least call another eye specialist that can help you with this issue. Over the years, I've developed an ebook that we do online, so people can sign up and get the ebook. And then along with that, they will, my web designer will send them emails periodically to say, hey, have you read the book? Here's something interesting, here's something new. Here's, another thing I do is, higher order aberration correction, and just keep people in the loop of what we can do and bring patients into our office. My web page, I think these are some shots from our web page. Testimonials are the number one. We happen to have, let's see, he's not on this one. Oh yeah, he is. The top left corner, Jay Mendoza, I can use his name. He's a YouTube influencer, and he does all kinds of product. He's probably making 7 figures doing this stuff, but he has keratoconus. He came to me, couldn't see. He actually was one of his clients is the LA Dodgers, and he plays poker with the Dodgers, and they used to call him the blind guy because he couldn't really see while I was playing. So I guess they probably took all his money. But he and I now are working on educational YouTube videos because he
Awesome.
also feels it. And I have patients that go, "Wow, I watch Jay. He makes me laugh, and he's made me realize that I can live a life." Because as we all know, a lot of keratoconics, there's a lot of depression and anxiety with this disease. And I take it for granted. I'm a keratoconic. It's never stopped me. Being an optometrist, as I already said, being an Ironman triathlete, doing whatever I want, and it shouldn't stop anybody. Maybe they can't be a Air Force fighter pilot because they have certain rules, but pretty much anything else in the world. And so get these testimonials from these patients of yours and post them and tell them, and I have someone will mention, wow, it was that eaglet profiler. And it went, I only had to go for a couple of visits instead of a ton of visits. And patients appreciate that also. Um,
Yeah, this is fantastic stuff. Thank you so much for sharing all of that. Perhaps we can we get a lot of questions from users saying, well, and we see that sometimes without getting questions, we see that practitioners, doctors, they struggle to integrate the eye surface profiler in their patient workflow.
yes.
And of course, you've been a customer now for a good number of years. But if you think back, so what kind of steps did you take, or how did you get into a full integrated patient workflow, including the ESP?
So we started years ago again with, and if you guys, you can certainly look at my web pages sometime to explain it more, but this sort of stepwise flow that we all sort of follow is, first is, getting vision and getting topographies and that. But once we realized, brought in the eaglet, we realized, yeah, where do we put that in? So in the beginning, we were, just say, let's do everybody. But as we all know, it's not real time consuming, but it does take a little extra work. And I don't really want to do it if I'm not going to use it. Now, sometimes we do it before I know, because as I was talking about earlier, it is a big selling tool in the chair. So once I put up on the, again, I'm sitting here in my exam room, but I have this big screen, the patient looks at it, and I start showing that rotating image and start measuring and showing them, we know right away it's a sales fit. So we want to integrate it in right away. But we have a flow, and it's training. In my office, my technicians are going to be, doing most all these tests, and they're very comfortable and familiar now with Eaglet. It's actually a very quick learning curve for those of you who aren't using it to use it. And so right away, I'm just going to tell them we all have walkie-talkies on us to have a good flow, and I can say, hey, I'm in exam room number 3, and we need to get an Eaglet. And so we have usually what we know of keratoconic patients, new keratoconic patients coming in, we've already put in their name and their other demographics. You really just need their name and birth date, and we have a patient number, so we can always find them through name or patient numbers. And they're going to be preloaded in there, so it's ready to go. We're going to explain to them here, we're going to just take another picture of your eye, just like you've done already with the other instruments. And the only difference is we're going to put this neat stuff in your eye that's going to make your eye glow in the dark. If they've worn lenses in the past elsewhere or with us before Eaglet, they're going to know what fluorescein is, and they go, oh, that's cool. And we're going to tell them, you're just going to sit there, we're going to open up your eyes, and they all find it pretty easy. So we right away will go and just put that in our workflow. Patient's going to come back in the room. I'm off doing something else, so the staff's going to tell me, hey, they're ready for you back in room number 3. Go back in and show that Eaglet design and help go through that design process with the patient, because now we do much more elaborate designs for anywhere from these bioelevations and microvaults all the way to these freeform lenses that can only be done with a profilometry. I mean, we all try to empirically fit these other lenses, and I do try to train other doctors and my interns how to fit a elevation lens, for instance, without profilometry, and you can get somewhere. You're never going to get all the way we do with an eaglet. But when I show patients, here's why we're going to do this and why it might cost this fee over and above your insurance if they have it, or why it's going to cost this much if they're a cash patient. I think that's very important educational tool. So it fits in there. And then part of the other flow is, I was just thinking of Arnie, is when patients come back, and as we all know, we all like to get that first lens fit, and we get pretty close to that with most eaglet design lenses. But when patients come back and we're trying then to troubleshoot an issue, whether maybe it's influx of some fluorescein causing fogging or impingement at a micro, at an elevation before we put microvolts in, we can then, I bring up in my screen here, my eaglet in front of me while I'm examining that patient, and I can say, hey, this is what makes sense. And again, show the patient the picture of maybe fluorescein influx through an area and say, look, here's the area. And now we can address that and fix that problem even faster when there are things that weren't identified sooner.
Awesome. Thank you. Thank you very much. Another thing that we hear often is around, of course, is growing your, particularly around scleral lenses, growing your patient base. And how would you say for your practice, how does the let's call it patient recruitment via referrals from ophthalmologists versus your other kind of marketing work relate?
Well, I think you need to let the ophthalmologist and optometrist in a large area around that you're the expert in this field and the technology that we use, because we use we have the eaglet scleral profilometer, we use an OCT. I also have high order aberration correction available. You got to show them that they're the person to do it. So if they're not going to do that, or they're doing the simple cases, you can help them with the hard cases, whatever role you're going to play, and how you can co-manage these patients together. Because just like we do with refractive surgeries or cataracts, we can all co-manage these together and make sure both optometrists and ophthalmologists know that we're going to share this patient. So these patients come to me and I'm going to fit that scleral lens, but they're going to go back to that referring doctor for their glasses, for their dry eye treatments, or anything else that they need. And that we make sure that that's understood right off the bat. So you got to, whether it's personally visiting other offices with some of your materials, hopefully you can bring them to your office and showing them these things. We've done some sort of open houses for eye care professionals. The last one we did, I think we had about 10 or 12 docs, a couple of local ophthalmologists and other optometrists. We had even a local internist, because these people are also going to refer to you. And once they know what you have and what you can do, they're pretty impressed. And then the proof's in the pudding. You do their first patient, and hopefully it all goes straight, and you can report back to them, and maybe even the patient reports back to them again, or you have that testimonial, either a video or a written testimonial that you can really show. So that the world is out there, and again, not everybody is going to be doing it with have a profilometer and that's a huge selling point for those outside referrals.
Okay, clear. So you really put considerable amount of effort into that. That is an ongoing process as well.
You need to, and we've done email campaigns, we've done snail mail campaigns, because you can get lists of ophthalmologists and optometrists in your area. And I had, with snail mail, we send out a few thousand or whatever it was, and you get a few responses. But I've also, 2 years later, that thing is sitting, it's off to the side. All of a sudden they go, yeah, who was that guy? And all of a sudden they came out with that. So you never know. But I think you got to go look more with social media and more electronic stuff, and you got to repeat it. You do have to repeat these things. I get stuff from a cataract surgeon. He used me, here's why I'm the greatest. Well, if they hit me over the head enough, I eventually maybe start talking to them, or they call me enough times. Maybe I go have dinner together, and it's just part of what we all got to do with all these other professionals that they share patients.
Thank you. There's a question from Dr. Hal Ostrom. Do you use fluorescein strips or do you use drops like GAT?
Yes. So actually here, I'm going to bring Gianni. He's over here doing my IT. You want to answer that, what you do on getting these patients ready for, I'm putting you on the spot. He wasn't ready for this, but he is, I don't know if you want to come on the camera.
Sure, yeah.
But he is what he does some of it, and he's trained our technicians and our other staff to do it. So we've come up with our system. I think works really well.
Yeah, so we use the fluorescein drops, correct?
Fluoresce.
I'm sorry, the fluoresce drops. And we also use Oasis Tears Plus, which is like a thicker gel eye drop. And that seems to work very well, to be honest with you.
Yeah, so I saw that one question. So the fluoresce has that little anesthetic in it, which does help, the patient comfort and holding their eye open and things like that. So, but that works real well. We've had occasionally with a graft patient, which has got some weird, huge elevation difference, and you can't get enough fluorescein on the over the outside the graft. Usually, we occasionally have. We did in the beginning. We were painting scleras with the fluoresce strips, and occasionally, I mean, one out of hundreds, we still have to paint a couple weird spots that just dried out. But other than that, that method works well with the fluoresce and the Oasis Tears Plus.
Yes, there are going to be patients with complex, compromised tear films that require some special attention, I'm sure.
Yeah, we just had a patient referred over that was unsuccessfully fit with another doc without profilometry. In the lab, they'd made 1 million lenses, and it was a graft patient, and her eye was so dry, it was very difficult to get. I think we shared some of these with Renier, and so we actually put her on Xydra and dry eye stuff for a month and had her come back. And then we did all our painting and we finally got good images and were able to get her fit successfully using Eaglet, which they were unsuccessful using any other system done. So it was pretty cool.
Awesome. Well, thank you so much. This has been really very enlightening. I see some comments in the questions as well, all pointing in the same direction. Thank you very much for sharing your pearls here this evening. And thank you also, Gianni, for helping out here. Really appreciate it. One quick question coming in. Can you this is from Dr. Paul Montague. Can you give us an estimate of what you use most often, or what you fit most often? RGP, reverse geometry, scleral, piggyback, soft. Do you reach for sclerals more now that you have the Eaglets?
I definitely do more sclerals. I mean, what I look at, some of the studies that were done by Pat Caroline and Mark Andrews up in Pacific University. A lot of you might know them, and they did a real good study that said, if you really have more than 300 microns elevation, delta in a cornea, it's very difficult, as we all know, to fit a small corneal RGP. And I use that as my guideline and talk to patients and show them the pictures, elevation map, and say, you have 800 microns or you have 200 microns and what our choices are. But I definitely can reach more to a scleral now, knowing how good of a lens we can make right off the bat. And I get, again, because I am a referral center, I get the worst of the worst in here. But you get a lot of people that have come in and, as they've failed with their small RGPs. They just aren't comfortable. And then I can say, well, this is why, here's why, and here's why we can do something more. But I still I wore for years myself, rose case and that. I'm much more happy now with my sclerals, especially with my sports. But I don't do as much, piggybacks anymore, because I think what I used to use piggybacks was a lot in the past was going from a reverse geometry RGB and having to use a piggyback. So now I'm going to go more for a scleral at that point. The same with hybrids. I mean, I think I can't adjust enough things for my liking, so I still use them occasionally, but the sclerals, I fit probably more of those now than anything else.
A follow-up question from Dr. Hal Ostrom is, and this is something we see as well quite regularly. It's around washout when you have to do a refit. Do you have a standard protocol for that? And also, how do you handle patients who refuse to well, just can organize themselves with the washout time?
Those which I've really only had a couple over all these years, I think legally with 7 years or so. I just say, look, we're going to do it old school then. I say you're going to have to put up with it the way I used to do it. It's going to take a long time and do all that. So the others, I don't know for any of you that were at ICSC a month ago or so in San Diego, they did a good presentation about washout, and it was sort of eye-opening, no pun intended, but because we've always sort of said, hey, let's do this 3 or 4 or 5 day washout. And I forget who it was that did a study. They showed, same day eaglet, 1 day washout, 2 day washout, 3 day washout, and how it wasn't changing as much as we would hope it was. I hope, by that, we try to tell them at least give me 3 days, and you still see something on the sclera. I mean, when do you not see it? How long would it take? And depends how that lens was fit and how hard it was smashing down on that sclera, and maybe how soft that sclera. We don't have a way to measure sponginess of a sclera yet, but we try to just tell them at least give me 3 days, and we've been doing well with that. So most people, if they work Monday through Friday, we say, hey, look, as early as you can on Friday, take your lens off. And I did this myself, go home and spend the whole weekend with looking at things 2 inches from my eyes and reading books and that, and then get someone in to drive you or Uber over on Monday or Tuesday, and then we'll eaglet you, and then you can wear your old lenses while you get the new ones in. You can also do one eye at a time, and those few patients that just can't, don't have glasses at work and all that. Again, if they have glasses, I had a patient today, she's 20/40 out of her glasses. She say, I'm fine, I'll be back in a week. And she can work, and she was okay driving. But those others, you say, okay, don't wear a lens in one eye for 3 days and do that one. And then we've done that a few times.
Yeah.
But 98% of patients, I would say, stop wearing them for 3 days, come in. We can check the effect on the maps and see if there is how big of an imprint there or left or not. And I think there's only been 2 patients at all that time. I said, you got to either wash out more or we're going to just do old school, and they just washed out more.
Very good, awesome. Yeah, and I'd like to point out to all of the listeners or all the people participating here is that we have user forum webinars. So these are exclusively for users, and in the last one, we actually covered how you can detect using the tangent angles map, which is a unique map for the ESP, how you can detect whether there's an imprint from the scleral lens. Because sometimes patients can be a little bit forgetful on when exactly they took their lens out, and but there is no hiding from the ESP. You will be able to see that and detect that at any time for a patient. So those kind of things we cover in user forums. We try to keep this going, do a lot of education for our users. We are very blessed with a very active user group, so we're very happy with that. And Dr. Leonard is one of our keen users, always there for those user forums, and also here tonight. So thank you again.
Yes.
It's been absolutely wonderful. Thank you for the questions coming in from the audience. Always appreciate it. If you have any thoughts later on, don't hesitate to reach out. You see the QR code in the bottom of the screen here. reach out for us. We're very happy to do a live demo or an online demo for you. And this can be in just 45 minutes. We can show you all the aspects of what this device could do for you. So with that, we'll end it here, and thank you, and hope to see you very soon on another activity, whether it's on site or online. And have a great evening. Bye bye.
Good night. Thank you.